Okay, let's dive in. Today, we're really unpacking one of the most complex, tightly regulated systems in the body, the female reproductive system.
That's right. And we're leaning heavily on Porth pathophysiology here to, cut through the complexity. We want to give you a clear path through the key structures, the whole dance of the menstrual cycle, and those crucial hormone loops.
Make those diagrams stick, basically.
Exactly. And the big theme that jumps out from Porth, it's this idea that the whole system is constantly responding dynamically to gonadotropic hormones. It's not static.
Right, across the entire lifespan. So we're connecting anatomy, physiology, and then, what happens when things go sideways, like with PCOS or menopause.
Precisely. It makes understanding the basic layout, the architecture, really critical.
Okay, so let's start right at the beginning. The external anatomy, the vulva, that's the collective term.
Yes, the vulva. It includes the mons pubis, that fatty pad up front, then the labia majora and minora, those protective folds, and of course, the clitoris.
And the clitoris is key, isn't it? Porth highlights its structure.
Absolutely. It's analogous to the male penis. It's erectile tissue packed with blood vessels and nerves, very sensitive. And the labia majora, the outer lips, they're actually analogous to the scrotum in males.
Okay. And inside the labia minora, we find the vestibule. What's in there?
The vestibule is like the entryway. It houses the urethral opening where urine comes out and the vaginal opening, the introitus. Plus, you've got the Skene and Bartholin glands there, which provide lubrication.
Ah, and that close proximity. Urethra and vagina right next to each other. That's clinically important, right?
Hugely important. It's why things like UTIs are so common. The potential for cross-contamination is just,
What?
it's built into the anatomy. Makes perfect sense when you see the layout.
Right. So moving inward from the vestibule, we get to the vagina, a fibromuscular tube.
Hmm.
What's its defining feature, physiologically speaking?
The environment itself, it's naturally acidic. Usually the pH is somewhere between, say, 3.8 and 4.2.
Acidic. Why?
It's a defense mechanism. That acidity helps keep harmful bacteria and yeasts in check. It's like a protective barrier.
Okay, so how does it stay acidic? Is it just naturally like that?
Not exactly. It depends on the normal vaginal flora, the
Ah.
good bacteria. Specifically, a type called lactobacilli or doderline bacilli.
Lactobacilli, like in yogurt.
Kind of, yeah. These bacteria metabolize glycogen, which is a sugar stored in the vaginal lining cells whose glycogen content is boosted by estrogen, by the way.
Okay.
And when the lactobacilli ferment that glycogen, the byproduct is lactic acid. That's what creates the acidic environment.
Ah, okay, so it's an ecosystem and disruptions. That's where infections come in.
Precisely. If you wipe out the lactobacilli, maybe with broad-spectrum antibiotics, then other things, like yeast, can overgrow.
Makes sense.
Or, flip side, if there's too much glycogen available, like in uncontrolled diabetes or even prediabetes, that extra food can also fuel the growth of potentially problematic organisms. So systemic health really impacts this local environment.
Fascinating. Okay, moving deeper. The uterus. Pear-shaped muscular, sits between the bladder and rectum. Let's talk layers. Porth emphasizes three.
Right. Outside in. First is the permetrium. It's the outer serous covering. And its closeness to the bladder is clinically relevant. Bladder infections can sometimes cause uterine discomfort.
Okay, outer layer. Then the big one.
The myometrium.
Yeah.
That's the thick middle layer of smooth muscles, the powerhouse
Powerhouse for...
for contractions.
Yeah.
It's what expels the uterine lining during menstruation, and of course, it's crucial for labor and delivery. That pain some women feel during their period, that's dysmenorrhea caused by these myometrial contractions.
Got it. And the innermost layer, the one that changes.
That's the endometrium. This is where the action happens cyclically. It has two parts, a basal layer, which is permanent and regenerates the lining, and a superficial layer, which is the part that thickens up and then sheds during menstruation if pregnancy doesn't occur.
Okay. And we can't forget the cervix, the sort of neck of the uterus.
Exactly. It projects down into the top of the vagina, creates little recesses called fornices. The cervix produces mucus, which is really interesting.
How
Well, this mucus acts like a gatekeeper. Most of the time, it's thick and forms a plug, protecting the uterus from infection. But around ovulation, under hormonal influence, it becomes thin and stretchy, almost like egg white.
to let sperm through.
You got it. AIDS, sperm transport. So its consistency changes dramatically throughout the cycle.
Clever design.
Yeah.
Okay, beyond the uterus, the fallopian tubes or oviducts.
Yep, slender tubes extending out towards the ovaries. They end in these finger-like projections called fimbria.
And the fimbriae do what?
They kind of sweep over the surface of the ovary around ovulation time, trying to catch the released egg, the ovum.
Catch it. And then the tube isn't just a passive pipe, is it?
Not at all. It's lined with cilia, tiny hairs, and has smooth muscle in its walls. Both work together to gently propel the ovum, which can't move on its own, down towards the uterus.
And fertilization usually happens in the tube.
That's right, typically in the outer or middle part of the fallopian tube.
Okay, leading us finally to the source, the ovaries. Dual function, Porth says.
Correct. Function 1. They are the reservoir for all the female germ cells, the ova, or eggs. A woman is born with all the eggs she'll ever have, and that number steadily declines over her lifetime.
Wow, a fixed supply. And function 2.
Hormone production. The ovaries manufacture the primary female sex hormones, estrogen and progesterone. Structurally, the outer part, cortex, is where the follicles containing the eggs are located. The inner medulla is mostly blood vessels and connective tissue.
All right, so we have the structures. Now the control system, this gets complicated, right? The hormones.
It does, but it's also elegant. Think of it as a communication loop. It starts higher up in the brain. The central nervous system influences the hypothalamus.
Hypothalamus releases.
GnRH, gonadotropin-releasing hormone. That travels just a short distance down to the anterior pituitary gland.
And the pituitary responds by releasing.
The gonadotropins, FSH, follicle-stimulating hormone, and LH, luteinizing hormone. These travel through the bloodstream to the ovaries and tell them what to do.
So brain, gut hypothalamus, GnRH, pituitary, FSH-LH, TESH, ovaries. That's the loop.
That's the core axis, yes. And the ovaries, in turn, produce estrogen and progesterone, which not only act on the reproductive organs, but also feed back to the hypothalamus and pituitary to regulate their own production. It's a feedback system.
And Porth mentioned something about energy, like body fat being important.
Absolutely critical. The body needs a certain minimum level of energy reserves, signaled partly by body fat percentage, to even start or maintain menstrual cycles. It's a biological go-no-go signal for reproduction.
Which explains why very low body weight, like in anorexia nervosa or extreme endurance athletes, can lead to amenorrhea periods stopping.
Exactly. The body perceives an energy crisis and shuts down the non-essential for survival reproductive functions.
Okay, let's dig into those ovarian hormones. Estrogens, there's more than one.
There are 3 main types, but estradiol, or E2, is the most potent and the most abundant during the reproductive years.
And its job.
Lots of jobs. Reproductively, it stimulates the growth of the uterus, fallopian tubes, vagina, promotes breast development, specifically the duct system, and it's responsible for that growth spurt during puberty.
But Porth really emphasizes the effects outside the reproductive system, doesn't it? The extragenital effects.
Yes, and this is huge for overall health. Estrogen is protective for bones. It decreases bone resorption, the breakdown of bone, essentially fighting against the effects of parathyroid hormone, PTH. This is key in preventing osteoporosis.
Okay, bone health. What else?
Cardiovascular health. Estrogen tends to improve cholesterol profiles, raising HDL, the good cholesterol, and lowering LDL, the bad. It also has direct beneficial effects on blood vessels, promoting vasodilation and having antioxidant properties.
Wow. So good for bones, good for the heart. Anything else major?
Neurological effects, too.
Yeah.
It's considered neurotropic and neuroprotective.
Yeah.
There's evidence suggesting it supports cognitive function and memory.
But there's a downside, the water retention thing.
Right. It does cause some sodium and water retention, which contributes to that feeling of bloating or slight weight gain some women experience before their period.
Okay, that's estrogen. What about progesterone? Where does it come from mainly?
After ovulation, the structure left behind in the ovary, the corpus luteum, starts pumping out large amounts of progesterone.
And its main roles.
Think progestation. It prepares the endometrium for a potential pregnancy, making it thick, glandular, and rich in nutrients. It also stimulates the glandular development in the breasts, getting them ready for potential milk production.
And it affects body temperature.
Yes. Progesterone causes a slight but measurable rise in basal body temperature right after ovulation. That's a classic sign used in fertility tracking.
Any other effects?
It relaxes smooth muscle. This is vital during pregnancy to keep the uterus from contracting prematurely. But that smooth muscle relaxation effect elsewhere can cause side effects like constipation or even headaches in pregnancy.
Right, trade-offs. Okay, let's connect these hormones to the actual cycle events. Follicle development, that's FSH's job.
Primarily, yes. FSH stimulates several primary follicles to start growing each cycle. Usually one follicle becomes dominant.
And the dominant one starts making.
Lots and lots of estrogen. As that dominant follicle grows, its estrogen production ramps up significantly.
Okay, high estrogen. Now, this is where that feedback loop gets interesting. What does high estrogen do to FSH?
It sends a negative feedback signal back to the pituitary, telling it to decrease FSH production. This is important because it prevents other follicles from developing fully in that same cycle. Saves resources, essentially.
Okay, so high estrogen shuts down FSH, but doesn't it also trigger something else?
Yes, this is the pivot point. While it inhibits FSH, that same high level of estrogen suddenly triggers a massive surge of the other gonadotropin, LH. It switches from negative feedback on FSH to positive feedback on LH.
A huge LH spike.
And
That's
boom,
what causes ovulation.
that's the trigger. The LH surge destabilizes the wall of the mature follicle, now called a Graafian follicle, causing it to rupture and release the oocyte, the egg. That's ovulation.
And sometimes that rupture causes a bit of pain.
Can do. Little localized pain around mid-cycle, known as Mittelschmerz German for middle pain, probably due to the follicle swelling or a bit of fluid blood leaking out.
Okay, egg released. What happens to the follicle left behind?
It collapses and transforms into the corpus luteum, the yellow body. And its new job, as we said, is to produce progesterone and also some estrogen.
And if pregnancy doesn't happen?
If there's no signal from a developing embryo, the corpus luteum lasts about 10-14 days, and then it degenerates, becoming scar tissue called the corpus albicans.
And when the corpus luteum dies,
The levels of progesterone and estrogen plummet. Without that hormonal support, the superficial layer of the endometrium breaks down and is shed. That's menstruation.
got it. So the endometrial phases match these hormonal shifts.
Perfectly. You have the proliferative phase first, driven by estrogen from the growing follicle, the lining builds up. Then, after ovulation, comes the secretory phase, driven by progesterone from the corpus luteum. The lining becomes glandular and ready. And if no pregnancy, the menstrual phase, the shedding.
Okay, that clarifies the normal cycle. Now let's apply this to altered states. Porth uses Polycystic Ovarian Syndrome, PCOS, as an example. What's the core issue there?
PCOS is complex, but often involves hormonal imbalance, particularly hyperandrogenism, too much androgen, like testosterone and problems with ovulation, often linked to insulin resistance and sometimes excess LH.
So symptoms like irregular periods, maybe acne, excess hair growth?
Exactly. The diagnosis, often using the Rotterdam criteria, requires looking for 2 out of 3. Irregular or no ovulation, clinical or lab signs of high androgens, and or polycystic appearing ovaries on ultrasound, lots of small follicles.
And the common treatment, OCPs, how do they help?
Oral contraceptive pills contain both estrogen and a progestin. This combination suppresses LH production, which reduces ovarian androgen production. Plus, the estrogen boosts a protein that binds up testosterone, and many progestins have direct anti-androgenic effects, so they tackle the hyperandrogenism.
Makes sense. Okay, let's shift gears to the other end of the reproductive lifespan, menopause.
Right. The natural cessation of menstrual cycles, usually happening between 48 and 55 years old. Perimenopause is the transition phase leading up to it, often marked by cycle irregularity.
And the mechanism is basically the ovaries run out of steam.
Essentially, yes. The supply of viable follicles dwindles, ovarian function declines, and as a result, estrogen production drops dramatically. FSH and LH levels actually go up as the pituitary tries harder and harder to stimulate unresponsive ovaries.
What are the main consequences of that estrogen drop?
They're widespread. Locally, in the reproductive tract, you get urogenital atrophy. The vaginal lining thins, becomes dry, less acidic pH goes above 4.5. This can cause discomfort, painful intercourse, dyspareunia, and urinary issues like urgency or incontinence.
And systemically, the infamous hot flashes.
Yes, vasomotor instability. Those sudden feelings of intense heat, flushing, sweating hot flashes, often followed by chills, also night sweats, palpitations, dizziness, sleep disturbances. It's thought to be related to the effects of estrogen withdrawal on the temperature regulation centers in the hypothalamus.
Okay, those are the more immediate symptoms. What about long-term risks after menopause, according to Porth?
2 big ones stand out due to the loss of estrogen's protective effects. First, accelerated osteoporosis. Bone breakdown starts to outpace bone formation. Second, a significant increase in cardiovascular disease risk. Atherosclerosis tends to progress more rapidly, and heart disease becomes the leading killer of women post-menopause.
Which leads us right into the hormone therapy, HT controversy. It used to be standard practice, right?
Oh, absolutely. Based on observational studies, it looked like HT dramatically cut heart disease risk, maybe by 50%, plus helped with bones and symptoms. It was widely prescribed for prevention.
Until the Women's Health Initiative, WHI, study, that changed everything.
Big time. The WHI was a large randomized controlled trial, the gold standard. And the main arm, testing combined estrogen plus progestin, was stopped early.
Why? What did it find?
It found an increased risk of coronary heart disease, stroke, blood clots, venous thromboembolism, and breast cancer in the women taking combined HT compared to placebo.
Wow. Increased risk, not decreased. But there were some benefits found.
Yes, both the combined HT and the estrogen-only arm for women without a uterus showed benefits like reduced risk of colorectal cancer and hip fractures. But the overall risk profile, especially for the combined therapy, was concerning.
So that just killed HT.
Not entirely, but it drastically changed how we think about it. A key factor that emerged later was the age of the women in the WHI. The average age was about 63. Many were 10, 15, even 20 years past menopause.
Ah, so maybe starting HT that late, when underlying disease might already be present, is different from starting it earlier.
That's the core of the critical window hypothesis. Subsequent analyses suggest that starting HT closer to the onset of menopause, say in women under 60 or within 10 years of their last period, might not carry the same cardiovascular risks and might even preserve some of the protective benefits, especially regarding coronary artery disease progression.
So the timing is crucial. What's the bottom line recommendation now?
It's very individualized. HT is definitely not recommended solely for preventing chronic diseases like heart disease or dementia. Its main role now is for managing moderate to severe menopausal symptoms that impact quality of life, like disruptive hot flashes.
And the rule is?
Use the lowest effective dose for the shortest duration necessary to manage those symptoms. Risk versus benefit needs constant reassessment for each individual woman.
Okay, clear. Let's quickly touch on the breasts. Structure.
Composed of glandular tissue, lobules where milk is made, ducts to carry milk, supportive fibrous connective tissue, including the Cooper ligaments that provide support, and fatty tissue, which makes up most of the volume.
And hormones drive their development.
Absolutely. Estrogen primarily stimulates the growth of the ductal system. Yeah. Progesterone is key for developing the alveolar secretory glands, the milk-producing parts.
And lactation making and releasing milk, another hormone loop.
Yep, connects back to the pituitary. Milk production is mainly driven by prolactin from the anterior pituitary.
But getting the milk out, the letdown reflex?
That's oxytocin, released from the posterior pituitary. When an infant suckles, sensory signals go to the hypothalamus, triggering oxytocin release. Oxytocin then travels to the breast and causes tiny muscle cells around the alveoli to contract, squeezing the milk out into the ducts.
Amazing feedback loop. Okay, let's wrap this up. If we pull back and look at the big picture from Porth.
What we see is this incredibly intricate interplay. The anatomy serves a precise physiological purpose, all orchestrated by that central GnRH-FSHL ovarian hormone feedback system. And this system doesn't just enable reproduction. It has profound lifelong implications for bone density, cardiovascular health, even brain function.
So key takeaways for everyone listening.
1. Remember, the vagina's protective acidic environment relies on that estrogen, glycogen, lactobacilli triad. Disruptions there open the door to infection. Estrogen's powerful non-reproductive roles, especially protecting bone and offering complex cardiovascular benefits, particularly earlier in life.
And 3.
Hormone therapy. The risks and benefits are highly dependent on timing. That critical window around menopause onset is key. It's not for long-term prevention anymore, but for targeted symptom relief. Lowest dose, shortest time.
Okay, so a final thought to leave people with, something to chew on.
Well, given everything we've learned about estrogen's effects, especially the neuroprotective ones Porth touches on, how might future research into that critical window change things? Could it eventually shift how we think about managing not just hot flashes, but maybe long-term brain health in women? It's a fascinating area to watch.
Definitely something to think about. Excellent overview.